or good morning to everyone. And this is the textbook for today's lecture, Gordon's Epidemiology, Chapter 2. Chapter 2. So epidemiology, Gordon's Epidemiology. It's a good textbook for epidemiology, and it's going to be Chapter 2 plus few pages from Chapter 1, the definition and the objectives of epidemiology. Okay, so let's start. By the end of this lecture, this chapter, in other words, you should be able to understand the following. First, concepts of disease transmission. We have concepts that you have to, we call them technical concepts. You have to use them when you talk about the transmission of disease. Plus also definition of epidemiology itself. What is epidemiology and why we study epidemiology? Then define terms like disease occurrence and epidemiology, as I said. Also, sometimes we have foodborne disease. When you go to a restaurant and eat, let's say, McDonald's or Burger King or KFC and these, you might get a problem. Foodborne disease. Your abdominal discomfort, abdominal unrest, and you keep going to the toilet after several hours. If you eat, let's say, KFC or McDonald's. What's happening? You have foodborne disease. Usually, when we want to see the magnitude of the problem, how big the problem is, we have to make incidence rate to see how many people got the disease at the same time. We call this attack rate. The incidence rate in foodborne diseases, we call it attack rate. Why? Because it's happening sudden and covering many people. It's the same incidence rate, but in foodborne, it's attack rate, like attacking. Okay. Also, we want to talk about the investigation of foodborne disease. We call it outbreak sometimes. Outbreak. We have a wedding, and then we have 10 people who got a problem during the wedding. How do we investigate? Which food is responsible? In a wedding, you have drinks, you have meat, you have fruits, you have vegetables, all sorts. One of them is the problem. One of the food is the problem. How do we investigate this? We will give you an idea, basic idea. Okay? And in order to make things, let's say, statistical, we use cross-tabulation. As I told you, epidemiology and statistics, they are intertwined. You know, they are very close to each other and they support each other. Statistics and epidemiology. This one, steps of outbreak investigation. How to, yes, this one, number 4. Exactly. So step 4, how, in order to investigate which food of the 10 foods maybe you serve 10 foods during the party or during Christmas or during an Eid, you serve 10 food, 10 items. One of them is the problem. One of them caused the problem. How to investigate this? We will give you a slight idea, basic idea. Okay? And to support this, we will talk about cross-tabulation, tables, cross-tabs. Okay, let's continue. That's just for you to study. That's just for students. First, you have to take notes. Some students sit down and they never take notes. They just listen. Yes? Maybe they are recording my voice, but much better for you as doctors and future scientists and let's say doctors and physicians is to take notes. Previously, we used to take notes using a pen and a paper. Nowadays, you have tablets, and you can just open your tablet on this lecture and add your notes and save them, you know, like other students doing. Also, much better for you is that what I'm talking, you can make it in the form of tables sometimes or figures. So this makes it easier for you to study. Flow charts, this, that, yes. Ask questions. You can ask me, and then I answer you. And take a note of this. Watch my videos or other videos, not necessarily my videos, and other videos over and over again to understand the point if you don't understand it. And finally, try to explain what you understood for your colleague. Explain as you are a teacher. Play the role of a teacher. One time he's a teacher and you are a student, and vice versa. And if you could deliver the message to him and he understands perfectly, it means that you have understood what I've said. Exactly. But if you didn't convey the message to your friend who's a student and you are the teacher, then it means that you didn't understand. And many times we think that we can do something, and when we try it, we fail. So what your ambition is something, and what you are doing or what your capability is another thing. Yeah. Yes, you can write, you can. So this is chapter 2, dynamics of disease transmission. How the disease is transmitted. Yes. Okay. As I told you, the first 2 slides, 3 slides are from chapter 1. Definition. Okay. So we have the language. Epidemiology is a Greek word. It's not English. It's a Greek word. It's epi on top of, like this is my laptop on the table. Epi on top of, yes, upon. And demos means people, like democracy, ruling the people by themselves. And logos is the study of logic, biology. So together it's epidemiology. Yes, epidemiology. That's the language. Let's go to the concept. What do we mean by epidemiology as science? If you remember in the public health, we define public health as 3 P's, 3 D's. Promote, prevent, preserve. Disease, death, disability. 3P, 3D. I like to do these mnemonics because they make it easier to memorize. Here we have another mnemonic. What is epidemiology? FD2. What is F, what is D, and what is D? 2 Ds. First, F is frequency. Let's go just before this. Again, it's a mnemonic. Just FD2 and finish. This is epidemiology. FD2. F is frequency. How much we have of this disease in our society? Incidence rate, prevalence rate, or prevalence rate. Prevalence is not a rate. Incidence is a rate. So we have 1,000 cases of COVID-19. That's how much we have. Or we have 10 cases of AIDS, for instance. We have 20 cases of breast cancer. That's the frequency, how much we have in a community. Usually you can give them in the form of raw data. We have, let's say in our city, we have 20 raw. Or to be more meaningful, we can give a rate. We have 1 per 100,000. 1 case in every 100,000. This is more professional. So frequency, you can give the raw number. We have 50, regardless how big is your city or your country. Or more professional, you can give a rate. We have, our city is 100,000. We have 20 cases. Then we have 20 per 100,000. Or our city is 1 million and we have 20 cases. Then we have 0.1, for instance, in 100,000. That's a rate. So this is the frequency, given as raw or given as rate. Then we have distribution. Distribution. As Sahar said, many diseases, they are in women. Breast cancer, mostly in women, mostly. Very few, rarely in men. Prostate cancer, in men. And many diseases like this. So diseases may be depending on sex. So this is what we call distribution. And the distribution has a model for this. It's PPT model. Person, place, time. So when you look at the disease distribution, you have to have 3 things in your mind. Person, is it a male or a female? Is it an old or a baby? Babies have diseases. Old people have different diseases. And adults have also diseases. So age, we look at age. That's person. Is the person African, or is he a Chinese, or is Indian or an Arab? Yes. So also ethnicity and plays role here, and so on. So the person plays role. The place also plays role. What do I mean? A disease like malaria, It's mainly in Africa. Malaria is an African disease. Now, according to WHO, 94% of the cases of malaria occur in Africa. So place. Lyme disease, Canada and the North and North Europe, Lyme disease, borreliasis, caused by Borrelia burgdorferi and others, or other species. Okay, and time. Some diseases they occur in summer, like diarrheal diseases, and some diseases occur in winter, like RTI diseases, respiratory tract infections. So when we talk about distribution, have the PPT model in your mind: person, place, time. That's the first D. The second D is determinants, the cause. What's the cause of disease? Is the disease caused by microorganism, or the disease is caused genetically, or by exposure to poison and pollution? So this is determinants, genetics, or family history, let's say. Okay, so FD2, frequency, distribution by PPT, and determinants, which is the cause. This is easier way to memorize what epidemiology is. FD2 and finished. Okay, let's go to the definition according to what's written in Prognosis epidemiology. He writes it like this. Look, study of frequency, distribution, and determinants. FDD, FD2, yes? Cause of health-related states, which means disease, or health adverse state. Some people, they use this term, health adverse, or adverse health state, okay? Or event. In general, it's a disease, okay? In human population, and why? Why do we study this? And the application of this study to prevent disease and control health problems. So why we study epidemiology? Because we have public health. Preserve, promote, and prevent, which means control at the end. Okay. This you can find it in chapter 1 in Prognosis epidemiology. Why do we study epidemiology? Objectives, goals. Do we study it for fun? Yes, some people, they study it for fun, like me. And plus, not only for fun, plus for the following reasons. Honestly, if you study epidemiology well, pure epidemiology, you will become a good researcher. Yes, good researcher. Because it's related with disease and how you study disease. You know, study designs, case control, RCTs, cohort studies. Epidemiology is very nice, especially if your knowledge in statistics is good. Mathematics is good, because mathematics, statistics, and epidemiology parallel. They run parallel with each other. Okay. So first, why we study disease? First, identify etiology and risk factors for disease. What is etiology? Sakhar, what's etiology? Very good. Etiology is good. Okay. And risk factors. So some diseases you can identify the cause, like HIV for AIDS, SARS-CoV-2 for COVID-19, Treponema for syphilis, Staph aureus for skin disease, for instance. Okay, you can identify easily. Some diseases, like cancer, for instance, you cannot, I mean, pinpoint, and you cannot mention the exact cause. It's multifactorial with many causes. Or diabetes, for instance. So you have, instead, we have risk factors. And why is it important to know the etiology or the risk factor for a disease? So in order to treat. Okay, then determine extent of a disease in a community. We call it burden of disease, BOD. How much we have of this disease in our community? Do we have only few cases, which is not a problem? Or we have large amount of cases that it's becoming a public health problem? It's a people's concern, like COVID-19, if you remember, during the pandemic. Hundreds of cases. Every society had hundreds and thousands and millions of cases. And WHO says that 7 million people died of the COVID-19 pandemic. 7 million. You can go to the WHO website and see the morbidity and mortality rates of this disease. Okay? We call this burden of disease. Usually burden of disease is measured by what we call prevalence. And we will talk about the prevalence, what is prevalence in the next chapter. Okay. And we have to know what is the magnitude of the problem and the extent of the problem in our society for planning how much diabetes we have in our society, so that Ministry of Health can buy the exact amount of metformin, for instance. Okay. Describe natural history of disease. Natural history and prognosis. What is natural history of disease? Anybody? No, it's not history. It means old and new. No, it's not. No, not very good. This is the idea. Exactly. So it's natural history of a disease. It's the progress and development of a disease in a person. Exactly, but in a person, assuming that you are not treating this person. I'll give you two examples. One example is the normal flu. Normal flu infects a person. It needs incubation period. 24 hours, 48 hours, you got the virus from somebody close to you, airborne, and then 24 hours, 48 maximum, you start feeling, sick, fever, fatigue, discomfort, and then you go to sleep and you need something or you need rest for this. After a couple of days, what happens? Flu, you revert, you come normal again. So this is the natural history of the disease. Incubation, symptoms, and then after a few days, you recover fully and everything is something of the past. Nothing happens. That's the natural history. If you go to pancreatic cancer, then you start with a cancer. Maybe you can diagnose cancer very early, or if you are unlucky, you diagnose cancer late, and then after this couple of months, and then you die. Flu, it's easy. Cancer, pancreatic cancer, death is your destiny. So this is the natural history of how do we know this? From previous cases, from the medical records throughout history. We know that this disease is mild. We know that disease is not mild. And this is what we call prognosis of disease. We have good prognosis of disease. We have bad prognosis. Flu, good prognosis. You will not die. Couple of days in the bed and it's over. Pancreatic cancer, very bad prognosis. Breast cancer, bad prognosis. Means you are going to die. So prognosis is different from diagnosis. Understood? Prognosis is something and diagnosis is another. Diagnosis is to identify the cause. Yeah, what is the cause of the disease? Diagnosis. What's happening in this person? Prognosis, what's going to happen to this person? What is the destiny? Yeah, prediction, exactly. Prediction, future. This person is going to die. He is pancreatic cancer and discovered late. Definitely is going to die. Poor prognosis. That's the idea. Natural history. Then, evaluate existing and new preventive and therapeutic methods. We all now know that, let's say, if you want to make diagnosis of something, you have many tests, not one test, many tests. Which test is more sensitive? Which test is more specific? In other words, which test is better than the other? So you have to read and you have to study and make studies to understand which test is better. The same thing for, let's say, treating people. You have one problem, but you have many treatments for this problem. Let's say, an example, kidney stone, renal calculi. You have surgery, which is an old method, and you have lithotripsy, the waves, shock waves. Which is better, this or that? Which is more expensive, this or that? Which is more invasive to the patient, this or that? Okay. We need studies. You make study on a group of people with lithotripsy and another study on a group of people who did surgery. And then you can get out with epidemiological study and statistics, which is better. So with epidemiology, we can evaluate methods. And these methods can be diagnostic, can be for treatment, and can be even can be administrative. Okay, how to deliver your healthcare. It's very important how to deliver effective delivery of. And provide information for public health policy towards environmental and genetic problems. At the end, we have a Ministry of Health. If every country has a Ministry of Health, or some group that is responsible for the health of the community in every country in the world. And these people, they need to make decisions. And these decisions, they mean millions of dollars and billions of dollars. Or these decisions can be sometimes detrimental, have very serious effects on the people, whether positive or negative. So in order to make these decisions, you cannot just dream of something and just say, I want to do this. You are a Minister of Health, and you should have studies in front of you. You should have reports. And who makes these reports? Experts, epidemiologists, doctors, lab, radiology, statisticians, yes, statisticians also. All of these people make study and then come up with a result. And this result is given to the Minister of Health, and the Minister of Health and the Cabinet, the Prime Minister, he says, I want this and that based on studies in front of me. So this is what we called, if you remember, what did we call this in public health? Last lecture. Evidence-based. Our Minister of Health cannot take decisions just haphazard. It should be evidence-based statistics and studies. And with these studies, he or she can make the correct decision, hopefully. Okay, so these are the 5 goals, at least mentioned in the book, why we study epidemiology. And they are very important. Number 6 is more fun, yeah, and teaching, maybe like us. But we make studies sometimes, yeah. Okay, so have a look here. This is another model which we call HAE model. This is called epidemiological triangle or triad. And this is something classical in epidemiology. What is this? This model explains the behavior of the disease in a person. How does disease behave in your body? Disease, in order to be produced, it has to be an interaction of these components. We have host, which is the person or the animal sometimes who's getting the disease, who's infected. And you have the agent, the causative agent of the disease. It can be living thing and it can be non-living thing. The disease can be just AIDS, or it can be just poisoning. Yeah, the same. Or it can be smoking, lung cancer, the same. Okay. And you have the environment. The environment surrounding you make the disease come to you easily, or prevents disease. I mean, enhances the disease or hinders the disease. Complex relationship, but we know it. It's complex, but we know it here. We know that any disease is a result of the interaction of these 3 components, major 3 components, and a 4th one in the middle, which we call vector. Sometimes the disease has to be transmitted to you through a vector, like mosquito. Malaria comes to us only through the bite of mosquito, Anopheles. Leishmania comes to us only through the biting of sandfly, phlebotomys. It is a vector. And vector ticks also, Lyme disease, TBRF, tick-borne relapsing fever, or we call them in general VBDs, vector-borne diseases, through vector. Very good. What's your name? Salim. Good, Salim. This tells us the interaction between these components, and then so that when they interact, we get the disease. And as Salim says, when you understand this, you can target any component of this to control the disease. You can target the victim, spraying. You can target the host, giving antibiotics or something. Yeah? End agent, an environment. You can target the environment by removing barrows, for instance, or removing swamps. And it's a breeding site for mosquito. You can dry swamps. This is the environment. So you can target the environment, you can target the agent and the host. Give the host antibiotics or treatment. So this is the idea. These 4 components, epidemiological triangle or triad. They explain to us the interaction of these components to produce disease. This is classical epidemiology. In every book you will find this. Yes. Ah, you mean good bacteria? Yes. Yes. Very good. I'll give you an example. I'll give you an example on what you're saying. Yes. Yes. That vaccine. What Sacher also proposed, this has been applied, which is making modification. What they did for, let's say, Victor, what they did for the Victor is they exposed the Victor to radiation. The males of mosquitoes, Anopheles, they were exposed to radiation. And these males became sterile. You know what sterile means? Cannot fertilize. And then they let these males go in nature. And when they go to the females, they mate together, but they never produce offspring. And in this way, they kill or they annihilate the whole population of Anopheles. That's one idea that has been used. Okay, I mean you have to have good brain and very clever to come up with new ideas. Exactly, it can happen. It can happen. I mean, you can go to the publication and see what many ideas. Some of them are practical and some of them not practical, honestly. Okay, so look, have a look at this. When I say, look, when we say human as host, there are many factors in the human being. It can be an animal, by the way, not only human, but because it's the humans that we care much about, it's not a vet lesson. So the age of the human. Age dictates the type of disease you get. When you are a newborn, your immune system is naive. When you are an old, your immune system becomes weak. And this dictates how much you get the disease. Very small dose of bacteria, parasite, very small dose. For a child or for an old person, elderly, can cause a problem, but not for you. For instance, sex, as we said, some diseases are sex-related, even genetic diseases, Marital status, occupation, what you work. We have a long list of occupational diseases, long list. Asthma, COPD, this, that, many diseases. They are related to occupation, what you work. Okay, race, as we said, many diseases are related to race. Tay-Sachs disease, Ashkenazi Jews, only for Jews. Thalassemia, Mediterranean, and somehow Armenians also. So we have diseases that are for special race. Religion. Indian people, they don't, for instance, Indian people do not eat beef, the cow, beef. So they don't get, most probably, they don't get Tinea saginata. Also the Muslims, Muslims do not eat pork. So very unlikely you will find Tinea solium, which is in the pork in Muslims. So religion plays a role. Some religions tell you to keep all the time dirty, and some religions tell you to keep all the time clean. There is difference between this religion and that religion that affects your health. Okay, immune status, as I told you, for the children and for the elderly. Genetic makeup, yes, your whole genome. Some people now, they sequence their whole genome so that they can just look if they have, let's say, breast cancer, BRCA1 and BRCA2 genes. Angelina Jolie, her mother, the grandmother, they had breast cancer. And when she tested, she was BRCA1 positive, BRCA2 positive, and she made a mastectomy before she got the disease. Genetic makeup. It was really a very painful and brave decision to have mastectomy before the disease. Brave decision. Okay, and then we have the agents. You might think that the agents are only biologic, bacteria, viruses, prions, parasites, this, but also the agents can be chemical. They can be alcohols. They can be poisons, arsenic, mercury, cyanide. All of these are poison. Smoke, you are smoking. Physical can be fire, radiation, trauma, car accident, fall. All of these are also agents. Okay, nutritional. We have people who do not have food, and we have people who have excess food. And ironically, cynically speaking, more people die of excess food in the world than people dying of lack of food. Ironically, this is happening. Yes. So nutrition, this is agent. So what you eat also is an agent. It can cause a problem to you and it can be healthy to you, both. Environment. What makes sometimes a host an agent, but you need the appropriate environment for this bacteria or this disease to exist. So you have the host, you have the agent, you have the vector, but the environment sometimes does not support, or it supports. What does environment mean? Crowdedness. If you are in a school, crowded university, in a jail, you are watching a football match. I remember there was a football match where Liverpool and Barcelona, I think, they met with each other. And after this match, 40,000 cases of corona, COVID-19. That was 5 years ago. You can go back and temperature, high temperature, low temperature. Some diseases in tropical areas, high temperatures, like malaria. Some diseases like Lyme disease in temperate areas. Canada, North Europe, only these areas. Humidity, climate also, climate change. New diseases, because we have climate change, and new diseases emerge. The snow in Antarctica and the North Pole, the snow melts, and viruses, new viruses which we never knew, come out and cause new diseases. Monkeypox, although people are talking about some lab making the monkeypox, but altitude, high and low. You have Mount Everest, 8,800 meters above the, yes, and you have Jericho in Palestine, minus 245 or minus 350 meters below sea level. Okay, season, some diseases come in winter, some diseases come in summer. Yeah, geography, as we said, malaria, mainly in Africa. Yeah, geography. Radiation, pollution. Countries that do not care about pollution, they have problems. Yangtze River in China, the biggest river in China, because they have industry on both sides of the river, chemical waste are poured into the river, and the river, if you go to the net, it's red, dark red, because of chemicals, pollution. Noise, also, noise. If you are living next to an airport, what happens to you? More stressful. Yeah, even if you sleep, if you are living next to an airport, for instance, even if you sleep, your brain is still awake. That's a problem. Housing. Yes, good housing versus bad housing. Neighborhood. Good neighborhood versus bad neighborhood. Yeah. Stress, psychology, and this stuff. So you have the epidemiological triangle or triad that explains the occurrence of a disease through these. And then finally in the middle, the vector. Mosquito, sandfly, ticks, and not necessarily also to be biological or something living. It can be also mental, and it can be also in the hospital. It can be the needle. It can be surgical tools. You have contaminated surgical tools that come to you and cause disease. Needle prick, finger prick by needle. Maybe the patient has AIDS or has hepatitis B disease. If you make finger prick and don't care and you are not vaccinated, then you get the disease. So vector can be something living and even something inanimate. I mean, it can be fomites. Okay. Mode of transmission, the transmission of disease, it can be direct and it can be indirect. Direct is from person to person, and you have to be close, less than 2 meters, because some people, they say airborne is indirect. People say it's direct. Some people say in between as a compromise. If you are less than 2 meters, then it's direct. If you are more than 2 meters, it's indirect. So person to person, it's direct, like TB, tuberculosis, STD, sexually transmitted disease. Indirect, no human to human contact. Example, common vehicle. You are eating. You are drinking something contaminated, water. Exactly. Salmonellosis and cholera. Okay. And that's one in common. And vector. As we said, vector. We have Anopheles for malaria, tick for Lyme disease, Aedes aegypti for West Nile fever, and many. So it can be indirect vector, and it can be common vehicle like food and water. We have this, look, direct, indirect, and vertical. What's vertical? Let's go for direct is the airborne. Example, tuberculosis, flu, aspergillosis. Aspergillosis, it's a fungal disease, Aspergillus niger. We are just a moment. Physical scabies, you know scabies? So you shake hands with people, you get the disease. That's physical. And sexually, intercourse, HIV, syphilis, gonorrhea, this, that, trichomonas also. All of these are only through sexual intercourse. Indirect is blood transfusion. Somebody gave you blood transfusion, and this was contaminated with AIDS, you get AIDS. And any other disease. Oral fecal by food. You eat or you drink, you get it. Example, amoebiasis, Entamoeba histolytica, cholera, used by Vibrio cholerae, and typhoid, Salmonella typhi. Okay. Transcutaneous, bite from a dog, you get rabies. Bite from a dog. Or cat scratch disease from a cat. Yes. Bartonellosis, Bartonella henseli. Okay. Vertical, vertically from the mother to the baby, fetus. Mother to the baby, fetus. And you can have CMV, you can have herpes 1 and herpes 2, you can have toxoplasma. All of these go from the mother to the fetus through placenta, transplacentally. And even not only that, some reports I read, breastfeeding. The mother is breastfeeding, the child gets AIDS in a certain percentage. Yes? No, I don't think so. Only I read about AIDS, and not all cases. Let's say 30%, 20%, not 100%. No, I don't think so. You have to read on this. But the HIV, I have read about this, but not 100%. The HIV, 20%, 30%. I mean, cases. Congenital, you just get this from birth, like CMV, cytomegalovirus. Okay. One last thing. Look here. Here is our body. What you are seeing is our body, and the pores and the ends of our body, infection sites. You have the mouth and the GIT. You have the lung here by air. You have the urogenital, sexually transmitted. You have the skin here. So through the skin, you can get arthropods, insects, VBDs, vector-borne diseases, like malaria and leishmania and West Nile. Through this. Also, you can get the needle, finger prick, also through skin. You can have scratch and injury, like Bartonella from cats, or Staphylococcus, or Streptococcus, or even tinea, which is a fungal disease. We call it ringworm, tinea pedis, tinea capitis, and tinea rubrum and angium. Yes. Also, you can get through the respiratory tract, TB, tuberculosis, inhaling. You inhale, and things go inside you, and you develop tuberculosis. Sexually transmitted disease, trichomonas, HIV, hepatitis B, syphilis, gonorrhea, and these are the main ones. So you can have here same agent, but getting in more than one route. The same agent, but more than one route. And also one route on the other side, you can get more than one bacteria or one organism inside. That's at the same time. Okay. So non-infection also, this applies not only to bacteria and microorganisms. This also applies to what? To chemicals, poison. Some poison you have to ingest. Some poison through the skin, filtration, and goes inside the skin. And some inhalation, like chlorine at home. If the lady, one of the ladies here, let's say she's all the time using concentrated chlorine for washing up. 10, 20 years, she will have lung problems because there is vapor coming out, fumes coming out, HCl, hydrochloric acid, fumes come out. So this applies for microorganisms and also applies for chemicals and poisons. Okay, I think this is it for today, guys. And see you next time. Any questions before we go? Okay, thank you very much.